Hello, everyone. Welcome back to the second lecture of the Primary Care Ultrasound series. Today, we'll be talking about renal, bladder, prostate, constipation, and then also the FAST exam, including ascites. Some of these slides are borrowed by the Global Ultrasound Institute. And the objectives of today is to remember the focused clinical questions to answer for each POCUS scan modality that we'll be discussing. Understand how to use bladder, prostate, renal, fast, constipation, POCUS in the primary care setting, and then understanding the limitations of POCUS in each scan modality, including the pearls and pitfalls. We'll start off with the case here, 65-year-old guy with acute flank pain. And so with this patient in mind, some of the questions that we can answer on ultrasound is there hydronephrosis present? How big is the bladder? Is there a post-void residual? Is there a component of BPH and measuring the prostate size? And as well as, is there constipation present? Is there any fecal infection present? So this is a patient, potentially coming in with flank pain, a dipstick with blood and red blood cells. And you might be wondering, is there a ureteral stone here? Or an elderly male patient with urinary retention. And is it a prostate issue? Is it a constipation? Is it both? So to review parts and positions, we'll be talking about kidney ultrasound first. And as we may remember, the right kidney sits a little bit lower than the left because of the big liver that's in the way on the right side. And when looking at the ultrasound, looking at the kidney under ultrasound, you'll see this kidney bean-shaped kidney, as you can see here, with the renal cortex, which is the outer portion of the kidney, as hypoechoic or sort of darker in color. And then the renal cortex is hyperechoic or bright white, whiter in color. And that's the normal appearance of a normal kidney. And as you can see, the other anatomy to know about is that there's going to be the pyramids that sit kind of on the border between the renal cortex and the renal pelvis, and then the calyces, the minor calyces leading into the major calyces, and then the ureter. So the probe to use is a curvilinear probe. Of course, when we're using the butterfly, it will be just the butterfly probe, but it will be important to use the appropriate preset, which is the abdominal preset setting. And as a general rule of thumb, pointing the probe marker towards the patient's head or towards the patient's right. So talking about hydronephrosis is a little bit about basically it's similar to looking and seeing a clogged sink. You don't normally see where that clog is, but you see sort of the backup buildup of pressure, which is the hydronephrosis. And so with hydronephrosis in the kidneys, it is fairly simple to see what is hydronephrosis, what's moderate or severe versus what's not hydronephrosis and normal. And so as you can see, the difference between the two is very easy to tell. On the left-hand side, this is your normal kidney, as we just talked about. We have the hyperechoic renal pelvis in sort of the middle here, and then the renal cortex surrounding, versus the image to the right, where you can see the blown calyces and this sort of bear claw-like appearance with the black color all in the middle here. These are the blown calyces indicative of moderate to severe hydronephrosis. Now, if you get good at grading hydronephrosis, then you can grade it into mild, moderate, or severe. But I find that in the beginner, looking at hydronephrosis, what's really important is seeing the difference between moderate and severe versus normal. Okay. Figuring out what is mild may be a little bit more difficult because there are normal variants where normal renal vasculature can mimic mild hydronephrosis, and you can only tell the difference between normal, sort of this normal variant by using a color Doppler or looking at the flow of the kidney vessels. When you put color Doppler over uh, hydronephrosis, there should be no color flow. So in terms of the protocol, in looking at the kidneys and finding the kidneys, it is fairly simple. You have the patient laying on their back, and then in order to maximize the space in between the ribs, you can have the patient place their hand above their head so that the ribs are the furthest apart. And then you can use the xiphoid process as a marker and draw a line from the xiphoid process to the mid-axillary line. Once you do that, you can plop the probe right there with the probe marker facing the patient's head. Once you place the probe there, you should be able to see um, what you want to see, which is you're right at the junction between the liver, the kidney, and the lung. And so this picture here is really just to show that when you place the probe towards the patient's head, you're going to have ribs that are obliquely fashioned in this way. So when you have the probe facing the patient's head, you may be in between ribs. You might encounter a rib here and there, and it may occlude your image. So in order to sneak in between the ribs, once you have your probe in this position with the probe marker facing the patient's head, you can actually turn the probe parallel to the ribs. So turning this end of the probe down by 10 or 20 degrees so you can become parallel between these ribs. That'll give you the best image. So once you're able to do that, you're going to be able to see the ultrasound image as you can see here. Topographic anatomy would be, of course, superiorly, you'll see your lung. In between lung and liver, you'll have your diaphragm. And then between your liver and kidney is your Morrison's pouch, and then the organs in between. So on ultrasound, again, it's diaphragm where it's this bright white hyperechoic curved structure. And then you see the back of the spine. So these are the bright white spines in the back. The liver has a very homogeneous appearance, and scattered within the liver, you see hepatic and portal veins. Morrison's pouch, the most sensitive spot for free fluid, and then the kidney, okay, the right kidney in this case. So this is an image of, again, that right upper quadrant where you see liver on screen left. You see kidney right in the middle here with the bright white renal pelvis in the middle. There's no obvious hydronephrosis here. And as you can see, as the scanner scans through this clip, there's a shadow that kind of comes in and out. These are rib shadows. And so in order to get those rib shadows out of the view, you just need to turn that probe 10 or 20 degrees down towards the bed. Okay, so you can be parallel to the ribs. But all in all, this is a very great image of these three organs, right? The lung on this side, the liver in the middle, and the kidney. Here is another picture of the kidney, and now we're looking at the kidney in the short axis. And so we're scanning through that kidney from one side to all the way to the other side. Okay. And again, there are some rib shadows in view here. In rib shadows, there's rib and then a shadow all the way down towards the bottom side of the image. Now here is a example of some of the sonographer using color Doppler centered on the kidney. The reason why is because, well, oftentimes if you're worried about mild hydro and you see a little bit of black sort of blown calyces in the middle or something that you suspect has blown calyces, you can put color Doppler over the kidney and see if those black areas light up with color, red or blue, right? And so if it does light up, that means these are just prominent renal vasculature, and this is a normal variant. Now, it's important to note that when you're using color Doppler, everything on the screen stays put. You must have your patient, hold their breath or just halt their breathing for a little bit, because what color Doppler does is it detects movement. That's how it detects the vasculature flow. And so if everything's moving in the screen, if your patient's breathing, then everything's going to light up. So it's important that everything on the screen should remain as still as possible, in addition to also your probe. It should also remain as still as possible. So here's just another video clip of a normal kidney, and this is your normal clip of a kidney. And so we talked about this, right? So we talked about the protocol in first finding the kidney on the right side. Then also looking at the left side, it's the same thing as the right. Instead of the liver, of course, you have your spleen. And remember how what we talked about how on the right side, the kidney is a little bit more inferior than the left kidney because of the big liver that's in the way. On the left, it's going to be a little bit more superior and a little bit more posterior. And so, it may be a little bit harder to find, especially because when you're scanning the left side, you have your stomach and your intestines that are all kind of in line with the probe as well. And so you may encounter a lot more sort of bowel gas, um, but it is still possible to see. So as you can see here, everything still remains the same, except the spleen looks a little brighter white. There's no circular hepatic veins or portal veins within the spleen. So here is a clip of the kidney that's seen right here on the left side. There's lots of rib shadows kind of coming through, and that's very normal. And so even if you encounter a few rib shadows, that's fine as long as you can see what you want to see. And here's yet another clip seeing that kidney in the short axis, and we're fanning through completely. And I'm not seeing any obvious hydra within that white center. And again, along with this normal protocol of looking at the kidney, first in its long axis, doing a clip of the kidney in the long axis, and then a clip of the kidney in the short axis. And then lastly, using color Doppler to take a look and make sure that there's no hydronephrosis, and taking a look at the color flow. So here are some pathology slides here. Is there any hydronephrosis seen in this clip here? And so looking at this kidney, it does look like there's some black areas that are right in the middle here. Let's see, in a little bit, you can see this little tidbit of this black area that's in the middle of this kidney. Now, as we place the color Doppler over it, it looks like the black area does not light up, which means that this is truly hydronephrosis and not prominent renal vasculature. So I would call this mild hydronephrosis, mild to moderate. Now, as opposed to this example, here in this black area here, this also looks like a little bit of mild hydro potentially. So we took a look with the color Doppler, and in fact, all the black area lights up. And so this is a case of a normal variant of prominent renal vasculature. So this is why color Doppler is important. It allows you to determine the difference between mild hydronephrosis and normal. As you can see from normal on the left versus pathologic hydronephrosis on the right. Now let's talk about bladder ultrasound, which is a very high yield exam in primary care settings. Bladder ultrasound is very easy to do, very simple to do, and you can accomplish this within minutes. You place the probe inferior to the umbilicus, and right at the right superior to the pubic symphysis. And so as you can see from this sonographer, they are placing the probe right inferior to the umbilicus, and they are doing their best to aim low. One of the most common pitfalls and one of the most common errors that I see in beginning ultrasonographers is they don't start low enough and they don't push hard enough or aim low enough. And so make sure that when you are scanning for the bladder, push down on the abdomen. You can compress more or less like an inch or more without causing the patient any pain whatsoever. And so I would encourage you to push quite a bit and aim aim lower than you think. And so when you're looking at the bladder in this axis, horizontal axis with the probe marker facing the patient's right, this is the transverse view of the bladder. You're scanning through from superior to inferior, and you're seeing the bladder in its full entirety. Next, if you want to take a look at the bladder in the longitudinal axis, you change the probe direction from pointing towards the patient's right to towards the patient's head. And in doing so, you're going to see the bladder now in the longitudinal axis. And so when calculating bladder volume, it's just like a cut fruit. You have two dimensions on one side and then the third dimension on the other side. So with the first two dimensions, this is done on the transverse axis. And so you bring calipers left and right, up and down. And these are your first two dimensions. It doesn't matter which one's length, which one's width, which one's height. And it will all even out. And so these are your two initial measurements. And then the third measurement will be done in the longitudinal axis, which is with the probe marker facing the patient's head, the longest diagonal from superficial to deep. And so starting from one corner and then going all the way to the other corner on the other side. So once you have your all these three dimensions, you multiply it by a bladder coefficient of 0.75, and that will be your bladder volume. Now, when looking for hydronephrosis, the absence of a hydronephrosis does not necessarily mean you can rule out a renal stone. It just could mean that the stone was not severe enough to cause hydronephrosis. Another pitfall is that, in the emergency room, potentially even urgent care setting, if your patient is very dehydrated, they're nauseous, they're vomiting, hydronephrosis may not be easily seen. And oftentimes in the emergency room settings, patients are hydrated first and then re-scanned again, and then the hydronephrosis, if truly present, will appear. And so many on much of the EM literature, they say they prehydrate the patient with half a liter before ultrasounding. And so just know that as a potential limitation when you're looking for hydronephrosis. So back to the case of that elderly gentleman with flank pain. It looks like this patient does have some moderate to severe hydronephrosis, and so this patient ended up being treated with for a ureteral stone with Flomax, pain control, and with adequate outpatient follow-up. Now let's talk about also, while we're in this realm of looking at the bladder, what's inferior to the bladder and next to the bladder, right? You can actually answer multiple questions right when you are looking at the bladder itself. And so here's another case, 80-year-old gentleman with lower urinary tract symptoms. He's never had his prostate examined before. However, of course, he adamantly defers this prostate exam because it is very invasive. And so while you are looking and trying to do a bladder volume calculation and taking a look at this patient's bladder, you also take a look at his prostate as well, because you've learned that this is a great tool, great non-invasive tool to take a look at the prostate. And you measure the prostate, and within a few moments, you are able to counsel the patient on the next steps regarding BPH treatment. And as you can see, the bladder is superficial here. However, what's inferior to the bladder is the prostate. The prostate is the immediate next organ that is deep to the bladder, and then the rectum is inferior to that. So to review, taking a look at the longitudinal view of the bladder, where the probe marker is facing the patient's head, you have your bladder superficially. Then in the male patient, you'll have your prostate. And then deep to the prostate is your rectum. Okay. On the transverse view, the horizontal view, you have your bladder, the prostate, and rectum. And then in the female patient, of course, bladder, uterus, rectum. So the prostate volume formula is just a tiny little bit different than the bladder volume formula. And the main difference is that coefficient. Length times width times height by a coefficient of 0.52. This coefficient is based off of sort of the shape of bladder and the shape of the prostate. And so for most settings and most places use this 0.52 for prostate and 0.75 for bladder. And so just like for the bladder, for the prostate, you're also doing the same thing. It's really the same concept. With the horizontal transverse view, you are getting two calipers, left and right, up and down, to measure the two dimensions of the prostate. And then on the longitudinal axis, with the probe marker facing the patient's head, you are getting the longest diagonal from up to down. Okay. And anything greater than 30 milliliters is considered a enlarged prostate. So how good is POCUS for prostate volume? Well, the American College of Radiology states that transabdominal ultrasound is a valid initial imaging modality, and it's accurate for small to moderate sized glands, but of course, um, be cautious with larger prostates because it could overestimate or underestimate the larger glands. Of course, it's dependent on operator use, and so the more you do, the more accurate it'll be. And we will talk more about the butterfly auto bladder AI calculator function of the bladder volume, but there may be a auto prostate volume estimation coming soon. So it's important to know how to do this so that you know how to manually do it. However, there are AI solutions coming soon, and so potentially that will make things a little easier. So all in all, fairly good for prostate volume. Another really high yield exam in the primary care setting, and also sort of in the same view as when you're looking for the bladder and the prostate, is looking for a big stool ball when in constipation. How often do you see patients in the primary care setting where they're constipated, or you think that they're constipated, and they're either elderly or adults or pediatric patients, and whether they're constipated because of opioid medication use or other reasons, dietary reasons, or other things, um, you could either treat this clinically because they have very convincing clinical symptoms, get an abdominal x-ray and see if there's a lot of stool on the x-ray, or consider using a non-invasive ultrasound solution. So what's the evidence for this? When we're talking about adults, there's some research out from our Japanese colleagues that the sensitivity and specificity for fecal impaction stool ball compared to CT and in a digital rectal exam has sensitivities and specificities that are in the 90th percentile. And handheld ultrasounds are also equally as accurate, as you can see in these two articles here. In these articles, they talk about how different degrees of fecal impaction can show up under ultrasound, and then they show the CT equivalent. And so R1 is a normal image where there is no stool ball in the rectum. And so you see your CT image on the top, ultrasound image on the bottom. And here you see the bladder, the prostate, and a normal rectum. R2 is a image of someone with fecal impaction. And so bladder, and then there's kind of this half moon crescent appearing sort of object that's right deep to the bladder. That's actually your stool ball casting a dirty shadow. And then as it gets even worse, as you get a bigger stool ball, there's going to be an even more hyperechoic half moon that you can see here, casting a dirty shadow. And as you can see, the difference between these two, it's just that this is a little bit more brighter white. Now, the scanning approach is the same as looking at a bladder and a prostate. And so you're looking in that suprapubic area, right at the pubic symphysis, transverse and longitudinal. So sort of horizontal and sort of towards the head, looking at the rectum both ways. Here's yet another image. And so the image on this right hand side here is your no retention. And so your normal rectum. Okay, so bladder, prostate, rectum. B is some stool, hard stool retention. And so bladder, and then at the half moon, the crescent shaped hyperechoic area with a shadow. And then they actually say here that with a bigger with more with the stool retention, you can even see sort of different characteristics. So half moon, that's brighter white. Okay. So here you can see A, stool retention, half moon shaped hyperechoic area, B, hard stool retention, crescent shaped hyperechoic area with a shadow. So different ways of seeing a big stool ball. How about in pediatrics? So very similarly, you're going to be seeing that same sort of half crescent shadow. However, in pediatric literature, they talk about measuring that transrectal diameter. And so in a systematic review meta-analysis study, they saw that there was this range from 2.4 to 3.8, and there's sensitivities that are kind of on the very low side, 68%, and specificities in the 80 percentile for looking for fecal impaction. And so, of course, sensitivities and specificities, not perfect, but another tool in your toolbox in assessing for fecal impaction outside of X-rays and outside of the digital rectal exam or further imaging. So in the pediatric literature, they talk about measuring the diameter of this stool ball. And if it's, of course, the more it's closer to 4 centimeters, the higher the accuracy. But they say anywhere from 2 or 3 to up to 4. And so I don't think the actual number is really decided yet, but as you can see, it is still looking for that half crescent. And again, a half crescent here as well. And this is a transrectal diameter of 4 centimeters. All right, now let's talk about the FAST exam and ascites to finish up. So the FAST exam is really helpful in the emergent scenario where you're working in the emergency department, you're looking and evaluating patients who are coming in for trauma scenarios. So the FAST exam is really named as the focused assessment with sonography and trauma. First developed in evaluation of trauma in the 70s, became part of the ATLS course in the 90s. And now this has largely replaced the diagnostic peritoneal lavage, which was a very old school method of instilling IV fluid into the intra-abdominal cavity after in a patient who's suspected to have an intra-abdominal bleed. Once you instill the IV fluid inside the abdomen, then you drain it back out and see if there's any blood. If there is, then that is a sign of free fluid. However, with ultrasound, this is a much easier way and non-invasive way of looking for free fluid. As you can see, sensitivities are fairly low in the adult and pediatric literature, but specificities, if you see it there, it's truly there and it's very high in the 96th percentile. In the primary care setting, of course, we're not going to be always seeing trauma patients, but it is still helpful to be able to tell if there is any free fluid, especially if you work in the acute setting. Let's say a patient that you suspect of having an ectopic is coming in to see you, which has happened to me, and there was some free fluid, and the patient was expedited back to the emergency room. Or you are seeing lots of patients with liver conditions and cirrhosis, and you want to see if they have any ascites. Well, ascites will appear as free fluid, right? And so this is a helpful tool to have and to be able to know how to utilize. So let's continue on. So focus clinical questions you want to answer for the FAST exam is there free fluid in the abdomen, in the thorax, and is there free fluid in the pericardium? There's four positions for the classic FAST exam. One on the right upper quadrant side, right where we're looking at the liver and the kidney. One on the left side, left upper quadrant side, looking for the free fluid between the spleen and the kidney. One in the suprapubic region side. This is to look for free fluid that's surrounding the bladder. And then lastly, the subxiphoid view, looking for fluid around the heart, so a pericardial effusion. And classically, when you're looking for this fast exam and free fluid, you are using one probe because it's supposed to be fast. In order to do this quickly and see if there is truly any free fluid. The probe you want to use is a curvilinear probe if you're using a cart-based machine, but when we're using butterflies, it's that butterfly probe with a abdomen setting. And again, it's the same place where you're looking. The first setting, the first place is that right upper quadrant. We talked about this. The the ribs are these obliquely lined ribs here, and so in order to sneak in between the ribs, if you have the probe facing the patient's head, rotate it 10 to 20 degrees down towards the bed to get the absolute best views. So I'm gonna zoom past this because we talked about this already, but topographically, lung, liver, and kidney, ultrasound image, lung, liver, and kidney right here. And a picture depicting why Morrison's pouch in the splenorenal recess is the first place for free fluid to be seen, and that's because when a patient is laying right on their back, these are the little gutter areas where free fluid likes to fill up first. And so free fluid, as you can see, is depicted and on ultrasound is black. And so this small little sliver of black is free fluid. And you can actually, in this example, you can see free fluid that's surrounding this liver here versus this image here. Is there any free fluid here that you can see? So this is again that lobe of the liver. Here's your kidney, and Morrison's pouch is right here. I don't see the same sliver of black in between the liver and the kidney here. This is a normal fast, not a positive fast. How about in this example? In this example, we see actually a few things here. We see the positive fast in between liver and kidney, and over here, this is the diaphragm, the curved diaphragm. And interestingly enough, these are the spines in the back of the patient, spine, right? And so normally all you can see only the spines that are inferior to the diaphragm here. But because there's the presence of pleural effusion here, whether it's filled with fluid or blood, this because there is fluid in the lungs, ultrasound waves can shoot through the lungs, shoot through the fluid, and then show the spines that are deep to this fluid here. And so this is actually what's called spine sign. When there is extension of the spines, the bright white spines in the back here, superior to the diaphragm, that's a positive spine sign, and that means that you have the presence of free fluid. Presence of pleural effusion. And this is actually a much more specific way of looking for pleural effusion compared to chest X-ray. And so this is a very easy way of looking for a pleural effusion. So in this one clip, you can see both free fluid in between liver and kidney and a pleural effusion. In the normal patient, like we were talking about, spines do not extend past the diaphragm because normal air-filled lung, it's think of air as kind of like the enemy of ultrasound. And so ultrasound waves can't penetrate all the way through and into the air and then highlight the spines that actually are present here. And so because the diaphragm is so curved, there is what's called the mirror image artifact. It shines and as the ultrasound waves shoot through the diaphragm, it interprets this highly reflective structure, and then it bounces off, certain things within the liver, and it gives a mirror image on the other side of the lung. This is a normal artifact for normal lung, and this is something that just to know about. Okay, um, but if you do see the extension of spines, think that there can be something else going on, like a pleural effusion. All right, so left upper quadrant, same thing. Instead of liver, we have spleen. We talked about this already, so I'm going to speed through this here. And again, pathology, seeing fluid on top of the spleen. And so this is fluid that's subdiaphragmatic, but on top of the spleen here. So this is free fluid. Here is another example, but this is actually normal. So normal diaphragm, normal spleen, normal kidney. There is no fluid here. There's no extension of spines past the diaphragm. No pleural effusion. Now, when looking at the bladder, we will take a look at the bladder in the sagittal or longitudinal axis and also in the transverse axis. So again, just like before, bladder, prostate, rectum, bladder, uterus, rectum. And then same thing when we're looking at the transverse pelvis, bladder, uterus or prostate, and then rectum. So as we're scanning through the pelvis here, we're seeing the bladder left to right, and then also superiorly and inferiorly, we're zooming and scanning through the entire structure of the bladder. Now, when we're looking for pathology in the FAST exam, what we're really looking for is fluid that's outside of this bladder. And so in this fashion, when we're scanning through this pathology equip, there is some free fluid that's seen outside of the bladder. This is pathologic. This is not contained within the bladder. And also looking here, usually the bladder is seen superficially, and then you see your uterus or prostate. However, in this scenario, you see fluid that's deep to the prostate or uterus, and so this is also free fluid that's not supposed to be there. Lastly, we'll talk briefly about the cardiac view. This is something that we are very unlikely to do in the primary care setting, but potentially, if you're looking for a pericardial effusion, this could be something to take a look at, and it's quite simple to do to see actually. And so, when using the probe, you are holding the probe overhand. The probe is flat, and imagine a beam going through the liver to the heart. So you're using the liver as a sonographic window to take a look at the heart. And so what you're really going to be able to see is the outline, the hyperechoic bright white outline of the heart. And then if there is fluid, then there will be fluid seen outside of this bright white. And then on top here, this is your liver. So you're using the liver as a window to see the heart. And so here is your normal heart that you can see. This is the liver, right? And so right next to the liver is your right ventricle, because that's the most anterior chamber of your heart. And you can work backwards from there. So right ventricle, right atrium, left ventricle. And so here we have that bright white pericardium that's seen surrounding the heart. And there is no pericardial effusion here, as opposed to this example. Very clear, dark pericardial effusion surrounding the heart. So this is circumferential. Some pearls and pitfalls. So when looking for free fluid, when it's acute, it's easier to see because free fluid is black. However, when it's been days and blood has a chance to clot, Similar, like for example, like a hematoma, and it's been days, and blood has a chance for that to clot. Clotted blood has a very similar appearance to soft tissue, and so just imagine blood being more gelatinous, more clotted. It's going to be hard to actually distinguish that under point of care ultrasound. So beware if you're looking for free fluid days after specific like trauma incident, that might mislead you if you see a negative fast. Some physiologic free fluid in the female pelvis can be normal. So the amount of times when you do an order like a trans-abdominal and pelvic ultrasound, and they say that there's a slight small amount of physiologic free fluid. Well, in the female pelvis, a small amount, like a very tiny amount, can be normal. And if you have high suspicion for free fluid, consider repeat scanning. Remember that that sensitivity is fairly low. And so, emergency room docs, if there's high suspicion, of course, they're going to be getting more imaging. But if there's an initial negative fast, you want to repeat the scan in 15, 30 minutes just to make sure that any free fluid that's a slow bleed can be caught as there is more and more of a bleed. And one pearl to really, remember and keep in mind is that fluid that's supposed to be there, for example, fluid in gallbladder, fluid in the bladder, it should be rounded. Same thing as things like in vessels. Vessels are round. However, pathologic free fluid has acute angles, and so that can be a good distinction between pathologic and versus normal. So it's time to scan. And so this is a cheat sheet of all the things that we've talked about today. We talked about fast scan, how to look for hydronephrosis, sort of that those four specific locations for the fast: the right, the left, the bladder, and the subxiphoid view. We talked about two volume equations. One is the length, width, and depth, and times 0.75. That's your bladder volume. And then for the prostate, a little different. It's 0.52 versus the 0.75. And we talked about hydronephrosis. So this is the end of this month's talk. And so basically, again, I encourage you to utilize POCUS in normal patients, patients with already known pathology, patients that you're already going to order an abdominal imaging scan. So that way you can really gain the confidence in figuring out if what you're truly seeing is truly there. Compare your ultrasound results to the radiology report. Consider how you would incorporate this in your own day to day and how this could be helpful for you. And let me know if you need anything. Okay.